renal blood vessels which enormously perfumes the kidney are affected secondarily in majority of the affected secondarily in majority of renal disease. Renal blood flow is controlled by systemic and local hemodynamic, hormonal, and intrinsic intrarenal mechanisms. Disease which disturb this controlling mechanism give rise to primary renal vascular lesions. When renal blood vessels are affected, then some pathological disease occur that is called renal vascular disease. So renal blood vessel is affected here. These diseases are most importantly hypertensive vascular disease, means benign and malignant nephrosclerosis, thrombotic microangiopathy, renal cortical necrosis, renal infarcts. So the most important part is hypertensive vascular disease. This is the most important part for you. And elevated arterial blood pressure is a major health problem, particularly in developed countries. A persistent sustained high blood pressure has damaging effect on the heart. When it is in heart, it is called hypertensive heart disease. When it affects brain, it is called cerebrovascular accident or stroke. When it affects kidney, it is called benign and malignant nephrosclerosis. Now, definition. Hypertension is a common disease in industrialized countries and accounts for 6% of death worldwide. Epidemiology studies have revealed that with elevation in systolic and diastolic blood pressure above normal in adults, there is a continuous increasing risk of cardiovascular disease, stroke, and renal disease. Hypertension is intimately linked with the kidney because kidney disease can be both a cause and consequence of increased blood pressure. It is very important for you to understand it is a cause and consequence of increased blood pressure. Hypertension is generally classified into two types: primary or essential hypertension and secondary hypertension. Primary hypertension, which the cause is unknown, and secondary hypertension, where we know the cause. That cause either in kidney, endocrine, or some other organ. According to clinical course, both essential and secondary hypertension may be benign or malignant. Benign hypertension is moderate elevation of blood pressure and the rise is slow over the years. About 90 to 95% patients of hypertension have benign hypertension. Most of the hypertension is benign hypertension. There are very few, rest 5% is malignant hypertension. Malignant hypertension কাকে বলে? When increasing blood pressure 200 by 140 millimeter Hg or more, then it is called malignant hypertension. And clinical features are papilledema, retinal hemorrhages, and hypertensive encephalopathy. Now, etiology classification. Essential hypertension, genetic factors, racial and environmental factors, risk factors modifying the course. Secondary hypertension, renal, among the renal, renovascular, renal parenchymal disease, endocrine, adrenocortical hyperfunction, hyperparathyroidism, and OCP, coarctation of aorta, neurogenic. Now, renal hypertension, the most important part. Hypertension produced by renal disease is called renal hypertension. Renal hypertension is subdivided by two groups. Renal vascular hypertension, occlusion of a major renal artery, preeclampsia, eclampsia, polyarteritis nodosa, fibrovascular dysplasia of renal artery, and renal parenchymal hypertension. In various types of glomerulonephritis, pyelonephritis, interstitial nephritis, diabetic nephropathy, amyloidosis, polycystic kidney disease, and renin-producing tumors. So it is divided into two parts, renal vascular hypertension and renal parenchymal hypertension. Broadly, we can divide in two parts. In either case, renal hypertension can be produced by one of the following three interrelated pathogenic mechanisms. Activation of Renin-Angiotensin System, or it is called RAAS system. Sodium and water retention, release of vasodepressor material. Among these three, most important is activation of Renin-Angiotensin System, RAAS system. So, you have to understand this very importantly. So, first occur decreased cardiac output, then decreased cardiac output will cause renal ischemia, and means blood will get lesser amount in kidney. And for that reason, glomerular filtration rate will decrease. And renin will secrete. It is synthesized from juxtaglomerular cell of kidney, JG cell. Release renin in circulation, and it will go to in liver. In liver, angiotensinogen, and this angiotensinogen will convert into angiotensin 1. This angiotensin 1 will convert into angiotensin 2 with the help of angiotensin converting enzyme. In the lungs, this angiotensin 2 present in lungs, and this angiotensin 2 AT1 receptor and AT2 receptor, and this angiotensin 2 will release aldosterone. Aldosterone secreted from adrenal cortex. It will release of aldosterone. This present in adrenal cortex, and this angiotensin 2 is the most potent naturally occurring vasoconstrictor, and it causes peripheral arteriolar vasoconstriction, and this angiotensin 2 will cause sodium and water retention. If sodium and water retention happen, then what will happen? Increased blood pressure, hypertension will occur. The other main effect of angiotensin 2 is to stimulate the adrenal cortex to secrete aldosterone, and it reabsorbs sodium and water. So angiotensin 2 increase blood pressure by two mechanisms. First mechanism is peripheral. It is a potent vasoconstrictor. So it is a peripheral arteriolar vasoconstriction. By arteriolar vasoconstriction, and second mechanism is reabsorption of sodium and water. By two mechanisms, angiotensin 2 increase the blood pressure. Effects of hypertension. Systemic hypertension causes major effects in three main organs: heart and big blood vessels, nervous system, and kidneys. The renal effects in the form of benign and malignant nephrosclerosis. Now, benign nephrosclerosis. Nephrosclerosis is the term used for the renal pathology associated with sclerosis of renal arterioles and small arteries. It is the most important pathology in nephrosclerosis. That sclerosis of renal arterioles and small arteries. That's why it is called nephrosclerosis. It may be benign, it may be malignant. It is strongly associated with hypertension, which can be both a cause and consequence of nephrosclerosis. Now, clinical features. Clinical features are headache, dizziness, palpitation, nervousness. Renal function test and urine examination are normal in early stage. In long-standing cases, there may be mild proteinuria with some hyaline or granular cast. Rarely, renal failure and uremia may occur. Now, morphology. Grossly, both the kidneys are affected equally and reduced in size and weight. In benign nephrosclerosis, kidney will be small. In malignant nephrosclerosis, we will see kidney will be larger. In benign, kidney will be small. Often weighing about 100 grams or less, the capsule is often adherent to the cortical surface. The surface of the kidney is finely granular and shows V-shaped areas of scarring. The cut surface shows firm kidney and narrow cortex. So these are the important points for you to remember. Reduced in size and weight, kidney will be finely granular and shows V-shaped areas of scarring and firm kidney and narrow cortex. These are all the features of benign nephrosclerosis. Now, there are some other causes of small contracted kidney. Number one is chronic glomerulonephritis, chronic pyelonephritis, benign nephrosclerosis, amyloidosis of the kidney, myeloma kidney, diabetic nephropathy. So, this is the gross picture of benign nephrosclerosis. Kidney is small, contracted. The capsule is adherent to the cortex and has granular depressed scar. These are granular depressed V-shaped scars. This is all. It is also. It is, you can see fine legally granularity of the surface. Now microscopically. Microscopically, there are primarily diffuse vascular changes which produce parenchymal changes secondarily as a result of ischemia. First is vascular changes. Changes in blood vessel involve arterioles and arteries up to the size of arcuate arteries, hyaline arteriosclerosis, intimal thickening due to proliferation of smooth muscle cells in the intima, parenchymal changes, glomerular shrinkage, deposition of collagen in bowel space, periglomerular fibrosis, tubular atrophy, fine interstitial fibrosis. Now this is the microscopical picture of benign nephrosclerosis. You can see these are the sclerosed glomerulus, fibrillous thickening of intima, that is called intimal thickening, and hyaline arteriosclerosis. Now malignant nephrosclerosis. Clinical features: malignant or accelerated hypertension with blood pressure of 200 by 140 mm or higher. Headache, dizziness, impaired vision are commonly found. The presence of papilledema distinguish malignant from benign case of hypertension. The urine frequently shows microscopic hematuria and proteinuria, azotemia, high BUN and serum creatinine, and uremia develops soon if malignant hypertension is not treated aggressively. Approximately 90% of patients die within 1 year from causes such as uremia, congestive heart failure, and cerebrovascular accident. Now morphology, gross. In case of malignant hypertension, superimposed on pre-existing benign nephrosclerosis, kidneys are small in size, shrunken, and reduced in weight. However, kidney of a patient who develops malignant hypertension in pure form, it is enlarged, edematous, and have petechial hemorrhage on the surface producing flea-bitten kidney. So, as I told earlier, benign nephrosclerosis, the kidney will be small, and in malignant nephrosclerosis, kidney will be larger. Now, microscopical. Vascular changes, there are more severe and involve the arterioles. There are two characteristic vascular changes, necrotizing arteriolitis and hyperplastic intimal sclerosis or alveolar skin proliferation is characterized by concentric lamina or proliferated smooth muscle cells, collagen basal membrane. And ischemic changes, the effects of vascular narrowing on the parenchyma include tubular loss, fine interstitial fibrosis, and foci of infarction necrosis. Now, this is the gross picture of malignant nephrosclerosis. Kidney is enlarged in size and weight, and these are the petechial hemorrhage, or it is called flea-bitten kidney. These are all petechial hemorrhage. Microscopical pictures, alveolar skin proliferation, it is called hyperplastic intimal sclerosis, fibrinoid necrosis, necrotizing arteriolitis. Now the second part is thrombotic microangiopathy. First part is over, that is nephrosclerosis. Nephrosclerosis हो गया ना, एबारे হচ্ছে thrombotic microangiopathy. Another vascular kidney disease. The term thrombotic microangiopathy encompasses a spectrum of clinical syndrome that includes thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. These two, HUS and TTP. HUS and TTP are caused by diverse insults that lead to thrombi in capillary and or arteriole in various tissue beds, including those of the kidney. So, thrombotic microangiopathy have two components, TTP and HUS. Thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Thrombotic microangiopathy characterized by microvascular thrombosis, microangiopathic hemolytic anemia, thrombocytopenia, TTP, and HUS. Now, causes of thrombotic microangiopathy. First is infection. Most important, E. coli, Shigella, Pseudomonas. Then drugs, mitomycin, cisplatin, cyclosporine. Autoimmune disease like scleroderma, SLE. Thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, pregnancy and preeclampsia, malignant hypertension. Clinical features. The common clinical manifestations, microangiopathic hemolytic anemia, thrombocytopenia, GIC, and eventually renal failure. This group of disorder is classified according to the current understanding of their association and or cause. Typical HUS, actually HUS is divided in two parts, typical and atypical. Typical HUS, that is diarrhea positive, means in typical HUS, diarrhea will present. Is most common, frequently associated with consumption of food contaminated by bacteria producing Shiga-like toxin. Typical HUS occur due to Shiga-like toxin. And atypical HUS, it is diarrhea negative, is associated with endothelial injury, including antiphospholipid antibodies, complications of pregnancy and OCP, vascular renal disease such as scleroderma and malignant hypertension, chemotherapeutic and immunosuppressive drugs and radiation. TTP is characterized by inherited or acquired deficiency of ADAMTS 13. ADAMTS 13 plays a critical role in TTP. What is this? ADAMTS 13 is a plasma metalloprotease that regulates the function of von Willebrand factor, VWF. TTF is characterized by formation of hyaline microthrombi in microcirculation of various organs due to aggregation of platelet. In idiopathic TTP, autoantibody against ADAMTS 13 linked to deficiency of ADAMTS 13. Normally, ADAMTS 13, what it is doing? ADAMTS 13 cleave or cut the von Willebrand factor. If ADAMTS 13 is absent, then von Willebrand factor will accumulate. It will be large. It will be large because no one is there to cut the von Willebrand factor. So von Willebrand factor will become very long and it will accumulate. Accumulation of ultra large VWF multimer that bind large number of platelet. Large number of platelet will aggregate and it will cause the blockage of vessel, and that's when microthrombi will produce. So, pathogenesis, endothelial injury. In typical HUS, the trigger for endothelial injury and activation is usually a Shiga-like toxin, while for inherited forms of atypical HUS, the cause of the endothelial injury appears to be excessive inappropriate activation of complement. The endothelial injury in HUS appears to cause platelet activation and thrombosis within the microvascular bed. In HUS, pathogenesis starts from endothelial injury in case of HUS. And in case of TTP, pathogenesis starts from non-von Willebrand factor. There is evidence that reduced endothelial production of prostaglandin I2 or PGI2 and nitric oxide, both inhibitors of platelet aggregation, contribute to thrombosis. Now the platelet aggregation. In contrast to HUS, in TTP the initiating event appears to be platelet aggregation induced by very large multimer of VWF, which accumulate due to a deficiency of ADAMTS 13 that cleaves VWF multimers into smaller size. The deficiency of ADAMTS 13 is most often caused by autoantibody that inhibit ADAMTS 13. So, very large VWF multimer can bind platelet surface glycoprotein and activate platelets spontaneously, providing a pathophysiologic explanation for the microthrombi that are observed in vascular beds. So, pathogenesis of HUS and TTP are different, not same. In case of HUS, it starts from endothelial injury and Shiga-like toxin, and in TTP, it is very large von Willebrand multimer due to and accumulate in the vessels and produce microthrombi. So, very large multimer, why it is producing? Due to platelet aggregation. And why it is occurring? Deficiency of ADAMTS 13. Because no one is there to cut the von Willebrand factor. Normally, ADAMTS 13 cut the von Willebrand factor. The pain type of manifestations of PTP include microangiopathic hemolytic anemia, hemolysis of red cell, in PBS, fragmented red cell, NRBC, reticulocytosis. Increased LDH, unconjugated bilirubin in serum, bleeding manifestations secondary to severe thrombocytopenia such as pathology, ecchymosis, epistaxis. Fluctuating neurologic dysfunction, renal abnormalities, proteinuria, hematuria, azotemia, and fever. So there are 5 features. Microangiopathic hemolytic anemia in PPS, we will find fragmented red cells, NRBC, reticulocytosis. Bleeding manifestations, fluctuating neurologic dysfunction, renal abnormalities, and fever. For unknown reason, in TTP, central nervous system involvement is the dominant feature, whereas renal involvement is seen in about 50% of patients. The clinical findings are dictated by distribution of the microthrombi, which are found in arterioles throughout the body, with plasma exchange, which remove autoantibody and provide functional adaptive carding. TTP can be treated successfully in more than 80% of patients. So treatment of TTP is plasma exchange. Now morphology. The lesions closely resemble those of malignant nephrosclerosis. Features are hypertensive necrosis of arterioles, thrombi in renal microvasculature, edema and of arterioles, consolidation, necrosis, and congestion of glomeruli. It is a fibrin stain showing thrombi in the glomerular capillaries. These all are thrombi. These are thrombi. Now, it is the third part of vascular kidney disease. Sickle cell nephropathy. But for you, most important is nephrosclerosis, then TTP, HUS. These are important. Sickle cell nephropathy, sickle cell disease, homozygous or trait heterozygous, may lead to a variety of alterations in renal morphology and function, some of which produce clinically significant abnormalities. The various manifestations are grouped under sickle cell nephropathy. The most common abnormalities are hematuria and the diminished concentrating ability. Patchy papillary necrosis may occur in both homozygotes and heterozygotes. This is sometimes associated with cortical scarring. Proteinuria is also common in sickle cell disease. Next is renal cortical necrosis. Renal cortical necrosis is infarction of renal cortex varying from microscopic foci to a situation where most of the renal cortex is destroyed. The megala, the juxtamedullary cortex, and the rim of cortex under the capsule are spared. The condition develops most commonly as an obstetrical emergency like eclampsia, preeclampsia. Other causes include septic shock, poisoning, severe trauma. The lesions may be focal, patchy, or diffuse. The gross and microscopic characteristics of infarcts of cortex are present. Patient presently having oliguria, anuria, hematuria. If the processes involve renal cortex extensively, acute renal failure and uremia develop and thrombosis is grave. It is the gross picture of diffuse cortical necrosis. Now, summary. Hypertension may be primary or essential hypertension in which the cause is unknown. In primary, we don't know the cause. In secondary, we know the cause. The cause may be kidney, endocrine, or some other organ. Clinically, hypertension may be benign or malignant hypertension in which there is marked sudden increase in blood pressure is known as case of hypertension. Main mechanism of essential hypertension or activation of renin-angiotensin pathway or RAAS pathway, while secondary hypertension may be due to endocrine, aortic coarctation or neurogenic causes. Systemic hypertension causes major effects in three main organs: heart and its blood vessels, nervous system, kidney. Condition that all lead to deposition of thrombi in the microvasculature, accompanied by red cell hemolysis, tissue ischemia, and organ dysfunction, and consumptive thrombocytopenia. In typical HUS, shiga-like toxin produced by bacteria, most commonly E. coli strain 0157H7 is responsible for producing platelet activation and thrombosis. In most cases of atypical HUS, aberration activation of complement due to inherited mutation or acquired autoantibody is the key pathologic abnormality. In TTP, deficiency of agampinase 13, a negative regulator of VWF or von Willebrand factor, permits the formation of abnormally large multimer of VWF that are capable of activating platelets. Then next, renal cortical necrosis and infarcts or some other disease of renal blood vessels.